Hi, I'm Dr. Faranak Kamangar, and welcome to the Future of Dermatology podcast. We're here to talk about the real science behind skin, the medical breakthroughs, the cosmetic innovations, and everything in between. We are back. I am so excited for today's guest. We have none other than Dr. Haley Naik, who this group knows very well. She is a board-certified dermatologist, of course, and professor out of the University of California, San Francisco, Stanford and Harvard-trained, an absolute genius, and teaches us all about Hidradenitis Suppurativa and does amazing things with advocacy. She was at our Half Moon Bay San Francisco Derm event 2 years ago, and I still hear about how amazing that panel was. So make sure you also catch her at our next SF Derm in August, where she'll be doing another panel as well. But today, what I'm really excited about is she's doing amazing work in advocacy, and I really want to understand it better. And if I want to understand it better, I know we all would love this conversation. So welcome, Dr. Naik. Thank you so much for joining.
Yeah, it's my pleasure. Thanks so much for that really kind introduction, Farah.
Yes, and you've been doing so much amazing work. I literally still hear about your Hidradenitis Suppurativa panel with your colleagues that you guys held a couple of years ago. There were so many pearls, and I'm so excited. There's probably so many advancements in the last 2 years. So I'm so excited for August.
Yeah, I think August's panel is going to be really great. We're excited to share a lot of what has been advanced in the HS space, both in terms of therapeutics and procedural advancements, care for pediatric patients, care for HS comorbidities, and also talking about how the GLP-1 agonists kind of fit into things. So I think August's panel is going to be very rich, and I look forward to that panel and that conversation.
Absolutely. And then anything before we dive into, because we chatted about these California specific bills and legislation that are very pertinent to all of us that we'll get into in just about 30 seconds to a minute. Before that, any one or two pearls that we should know about HS or any highlights, exciting things that are happening right now before the August session?
Yeah, I think a few things to know, a couple things to know. One, we now have 3 FDA-approved therapies for HS in adalimumab, secukinumab, and Bimzelx. There are 2 additional agents that we're anticipating will make it across the finish line in the next year or so in povorcitinib, which is a therapeutic made by Incyte. It's a JAK1 inhibitor. And then Moonlake Therapeutics actually has a IL-17 ANF nanobody, which we anticipate it'll also make it across the finish line in 2027. So more therapeutics coming to help us care for our patients with HS. And then the other thing that I think is important for people to know is that through really years of advocacy by HS patients and physicians who care for them, and really led by the Hidradenitis Suppurativa Foundation, our advocacy efforts have led to a pretty big research funding advancement, which is that HS has been included as one of the highlighted topics for funding at the NIH across 3 institutes, which is huge. It means that the NIH wants to fund HS research, is excited to do so, wants to advance care and knowledge about this condition. And I think it's also important to know that the highlighted topic remains highlighted for a year. So it's important that folks who are interested in putting forth research applications for HS in response to these highlighted topics, they get their applications in during this 1-year period, which starts April 7th, 2026 and ends a year later in 2027.
Thank you for that. That's very time sensitive. Thank you for letting us know. I mean, that literally just happened this April. So, and we always love breaking time sensitive things and the latest in the news here. So I'm sure there's lots of researchers who can benefit from these grants to advance their research, it's important to know that 1 year deadline. So everyone get on it. I'm glad we talked about that now before August, so they don't lose a few months.
Yeah.
And
sure.
let's get into the advocacy part. So another kind of, I think, time sensitive, but you can let us know timelines of these California state bills. Every once in a while, I see something legislation wise or bills come through. And I have to say, my focus is more on education and dermatology content. And of course, there's bills that come and they're kind of interesting. The ones that you highlighted, I was like, whoa, these are really important. I was like, what is this again? So I'll let you take it away, but let us know kind of because this sounds like if these things pass, we can have actual daily practice improvements in how we do things. So
Yeah,
I'd love to hear more.
there are a lot of kind of interesting, exciting, potentially practice changing bills that are on the docket. And as you said, they are time sensitive. There's an opportunity to be voting for these bills, within weeks. I think folks are getting their California ballots now. So it's great that we're having this conversation. I think before I dive into the bills, probably important for us to kind of ground ourselves in what the prior authorization process looks like. What I'm going to talk about really has to do, the bills I'm going to talk about really have to do with the prior auth process. So, I think we all know and would agree that lots of parts in this system of treatment access is broken. And I don't think that's a view that's shared solely by physicians, other providers, and patients. That's also a view that's shared by health insurers, right? I mean, the Blue Shield CEO, Paul Markovich, publicly acknowledged that the prior authorization process is broken. And in summer of 2025, the insurance industry issued a voluntary streamlining pledge for the prior auth system. So I think everyone's trying to figure out, like, how do we make this system better? And, if I think about my own patients, I'm sure our listeners will have kind of analogous examples of what getting them the care that we want them to have to improve their skin disease looks like, right? Like, you put in a prescription and it gets denied. And what are the reasons that a prescription might get denied? Maybe there's like some step therapy requirements. They have to try this, that, and the next thing before we can get your patient the drug you think is most likely to help them. If a drug gets denied, there may be an opportunity for a peer-to-peer. Oftentimes, in my care of patients with hidradenitis suppurativa, the person I'm speaking with is not only not a dermatologist, the peer I'm speaking with is not only not a dermatologist, they're probably not even a physician, right? Then, there's kind of a whole process for appeals and, in the process of getting denial letters or any kind of, approval letters, there's no indication of who the decision makers are. So you don't even know really who to reach out to. And then when you finally get this drug approved, right now, what happens is that the drug is approved for a certain amount of time, and that time is often not very lengthy. Usually, for some of our drugs, like as short as 3 months, right? So then you get it approved, and then you need to see this person back with some frequency and complete the paperwork with some frequency to ensure that they continue to get the benefit of that medication and there are no gaps in care. There's good data to support that 25%, a quarter of dermatology visits require prior authorization, which is a lot. And, we know the majority, like 3/4 of the denial letters that we get in dermatology don't have a listed decision maker. So we don't know who to contact. And I think it was a recent study that shared that on average, the average dermatology practice spends $40,000 a year to staff for prior authorizations, right? So it's like it comes at a cost not only for patients and their care, it comes at a cost for like trying to keep practices open and provide care and have access for patients. So it's like a big problem, right? So there's a bill that's on the docket, AB 539, that is attempting to at least address one part of this process. The bill requires that an approved prior authorization for a healthcare service is maintained for a 1-year period from the date of approval. So not 3 months, but really extends that prior authorization for a year or for the full course of the prescribed treatment if the treatment period is meant to be shorter than a year. And this is, I think, really critically important bill for people with chronic diseases who need chronic treatment for their chronic conditions, really will serve to help eliminate or at least very much reduce gaps in care, help with this issue of kind of prior authorization paperwork and staffing that we're struggling with. And for patients with HS, I'll speak, just within my area of expertise, for people who have had a 7 to 10 year diagnostic delay, just 7 to 10 year delay in getting a diagnosis of HS, making sure that they get on the treatment they need and don't have this additional hurdle of trying to get a reauthorization every 3 months is going to be huge. So I'm pretty excited about that one.
No, that's so great. I mean, I think the problem of the reauthorization cannot be understated. And I feel like, I mean, I don't know the exact data, but just I feel like in clinic, it's happening more and more in the past few years. I felt like there was a phase where every once in a while you would see that. But once you did the hard work, all the hours, got something covered, you were good and patients were off. But then this whole like, oh, actually, you need to repeat this whole process again, like not that far out from when you started it.
Yeah.
And then, like you said, there could be a delay in the medication getting shipped to the patient. So that's horrible. Like we finally got them on the right thing. They're getting better. Oh, just kidding. You're going to be off your medication for whatever amount of weeks to, so this gets figured out. And then your staff is doing it all over again. Then there was a while where I actually kind of was confused. I'm like, what do they want? Because they would come back and say, oh, I don't see a tried and failed. I'm like, well, no, we did that before. Now we're on the thing that works. So we're past the trying and failing. I mean, we just want to maintain. So
it's confusing for everybody, right?
Confusing
it
for
creates
everyone.
More work for everybody.
Then this would be huge. I think when I saw that, I was like, oh, wow, like that is really impactful on so many ways. Patient care, your staff not going crazy on the phone back and forth trying to figure out who to call, the mental health of your staff, dollar amounts, which I'm sure like that study was so interesting with the 40,000 and probably I'm guessing that's, well, I don't know if that was nationwide, but it's probably higher in the Bay Area because staffing just costs more, here completely. To do. So, I mean, that I think would be huge. And again, what are the logistics of what do we need to do? Do we all need to go vote for it? Like what percentage do these things need to get yeses to pass? I mean, it seems like a no-brainer, or who would go and vote no for that? Like that just seems like a hopefully should pass kind of bill.
Yeah. Well, I think, there's an argument that's been made on the health insurer side that, extending prior authorizations beyond these kind of very circumscribed periods increases healthcare costs, is not a good utilization measure. And I think that the truth of the matter is that if we don't get our patients, particularly with chronic conditions, if we don't get them the drugs they need when they need them, it lands folks in the hospital, right? It increases healthcare costs in a different way. Maybe not on the medication side, but on the inpatient side, in terms of also impacts people's ability to seek gainful employment. I think we don't think about that. Maybe we as dermatologists think about that, but I think the broader community may not think about like how having severe atopic dermatitis, severe HS, severe psoriasis impacts people's ability to participate in the economy, and continue to seek gainful employment and be contributing members of our community. And that's really what dermatologic care allows for people, right? So just
Absolutely.
in terms of kind of like what people can do, I think people can call their state representative, they can call their assembly member and let them know that they're very much in support of AB 539, and speak to their own experience caring for patients with, XYZ condition. If you're a patient or you're a trainee, I think kind of speaking to the importance of how care has impacted you or caring for others has impacted health, is another approach when calling your representatives.
Oh, that's great. It sounds like we all just have to keep up the good work of promoting that these conditions, these chronic conditions, are not just skin deep. And I think like yourself and so many of the psoriasis, atopic dermatitis experts, like they've done so much work in this space of there's the comorbidities, like all of the quality of life measurements that show, like for psoriasis patients, that even living with chronic psoriasis was sometimes even perceived as worse than even some cancers or heart conditions. I mean, I think it's just also, like you mentioned, might be a different story to try to explain that to someone, especially if you're doing a peer-to-peer with a non-physician as well, versus something that might be more obvious to everyone. Like if someone's on a diabetes medication, maybe that's,
Yeah.
so it's really just also educating on what chronic inflammatory skin disease means for someone.
Yeah. And I think, I think the case feels easy to make for HS and atopic dermatitis and psoriasis, but it's also equally important for things like acne, perioral dermatitis, some of the things that we treat that we know debilitates patients and makes it very difficult to participate in their lives. So this is a bill that, doesn't just impact complex medical dermatology, it impacts general dermatology, it impacts our day-to-day care. So it's important for us to engage.
Yeah, absolutely. And then there was a second bill, correct, too? There was
Yeah,
another
I
on
think
the docket.
there are actually two other bills that I think are kind of important and interesting. So there's also AB 2000, which is a bill that prohibits healthcare service plans or health insurers that maintain drug formularies from making mid-year formulary changes, which I think is really important because if somebody's doing well and has stable disease on a drug, having a mid-year formulary change can be very disruptive, not only in terms of their ability to get the therapy that was helping them, but also in terms of like out-of-pocket costs, what it means if they want to continue on that therapy, which is now not on formulary. Sometimes what happens is that to get to the next best drug for themselves, they have to go back through these step therapy requirements, which creates more hurdles. So this bill, I think, is important for our patients, in terms of kind of making sure that they can maintain the access to therapies that are helping their condition, and really making sure that physician autonomy in terms of being able to provide patients with the care we know is going to be best for them is maintained.
Yeah,
So that
that's a great window. As a physician, that one again is a no-brainer to me. But I'm sure maybe on the business side for different companies, there could be a rebuttal to that. But I mean, yeah, that's horrible if someone is on a medication or maybe they chose their insurance plan specifically because of the formulary that year. The patients usually can't change their insurance plans mid-year, right? They have to wait till open enrollment. So it doesn't make sense for them to have kind of made a health decision and then all of a sudden like the rug is kind of pulled out from under their feet. So again, seems like another no-brainer. Hopefully that one passes.
Yeah, I mean, this is really a systems issue, right? Like, do we or do we not have timelines and structures for making these changes? And like you said, there's probably a business case for this, but we are in the quote business of medicine and healthcare, right? So what should precede that? Obviously, I speak from the position of a provider, but the goal here is to optimize health. And so every decision we make about structures must account for that ultimate mission and goal.
Is the third one worth
mentioning as well? Is it
Yeah,
one that
so the
might
third,
affect dermatology?
yeah, I think the third is worth mentioning. So this is SB 1094, and this is a bill that CMA, the California Medical Association, actually opposes. Um, and I think it's worth knowing about. So currently, California pharmacists can only substitute a biologic with an interchangeable biological product. And what that means is that if you prescribe, for example, Humira or adalimumab, a California pharmacist can only substitute a biosimilar that has produced the same clinical result as Humira, and that switching and has demonstrated that switching back and forth between Humira and this other biological product doesn't increase safety or efficacy risk. So it has to meet this higher FDA designation. The SB 1094 actually expands California's substitution authority, expands the pharmacist's ability to not just change your prescription to an interchangeable biologic, but to any biosimilar. So really not only impacts, I think the goal here, if I'm being generous, is to keep healthcare costs down, which is a laudable goal. But I think what the impact of this for patients is that they may be doing well on a drug, and now somebody else, not their physician, has made a choice, oftentimes unbeknownst to their physician, made a choice to change your prescription to a biosimilar that doesn't have the same data supporting its efficacy and safety. So just purely from is this safe for patients? Is this good for patients? I think the answer as it relates to this bill is potentially no. And so SB 1094 is a bill that we're opposing.
Oh my gosh. I mean, that complex medications like this, or like you mentioned, even sometimes dermatologists that do complex dermatology prescribe these medications, and some general dermatologists don't. So to think about in that context is even our fellow board certified dermatologists are sometimes outsourcing this to a doctor that does complex medical derm. So then for this decision to be made by someone who's not even in the field of dermatology, it just that doesn't sound right at all. Like there's no way that is going to just accidentally turn out well.
Yeah.
That's
I
not
mean,
something that should be allowed.
Again, the North Star is health, optimizing health, right? And so if we're making these decisions, let's make decisions that are in the best interest of people and their health. And this is really rife with the potential for safety risks and really not meeting that North Star. So yeah, I think this is one drug to know about, one bill worth knowing about, and really making sure that we're voting in the interest of our patients.
So, well, thank you so much for reviewing that. We'll put links to all of these things below in the show notes as well. And just thank you so much for all of your wisdom and knowledge. You're always educating us on so many aspects. And today, I feel like it's a whole other world. I just started learning about. I'm going to look out for the voting. I think that's the most important thing that we all need to.
When these ballots need to,
ballots go out.
Your votes go in. So pay attention to that deadline. Your votes matter. It's kind of one of the only ways that you can make sure that your voice is heard. The other way is calling your assembly member, calling your state rep, and making sure that they know how you feel about these specific bills.
That's great. And then we always, being the Future of Dermatology podcast, at the end, we always ask what you're excited about in the future of dermatology.
Yeah, well, I am, as always, excited about HS and what's coming down the pipeline for hidradenitis suppurativa in terms of changing the lives of people living with this condition. I think there are, a lot of great therapies that are coming in 2027 and beyond. There are over 50 therapies in the therapeutic pipeline right now for HS, which is huge if you think about, the fact that we really didn't have anything for patients before 2015. This is like a boon, not born out of thin air, but born out of really sustained and strategic advocacy. I'm also, I am relatively new to this advocacy and policy space, and I'm really excited about what engagement can achieve for our patients, right? For years now, I've been involved in hidradenitis specifics policy and advocacy, but really thinking more broadly about our specialty and paying attention to bills like this. I think we have a real opportunity to affect big systems change, which impacts our patients and impacts our practice. And seeing the fruits of advocacy is really exciting. So those are kind of some of the things that are top of mind today.
Absolutely. And thank you again so much. And I'm really looking forward to August and the Hidradenitis Suppurativa panel. It is a field that is booming. And I know anytime that happens, it's almost hard to keep up with all the data as well. So really excited to just see all the updates, get the numbers of which treatments are working best. We'll put a link to that as well. That'll be the end of August in Palo Alto, California. So hopefully we'll see lots of derms there. But thank you again, Dr. Naik. It was wonderful having you on the podcast.
Yeah, it was very much my pleasure, and thanks for all you do.
Thanks for joining us today on the Future of Dermatology podcast. If you enjoyed learning about the science behind skin, make sure to subscribe, and we'll see you next time. As a reminder, this podcast is for educational purposes only, not for medical advice. Always consult your healthcare provider.